Satisfying Sex After Prostate Cancer. So our presenters this evening, starting with Dr. John Robinson. Dr. Robinson is a clinical psychologist with the Tom Baker Cancer Centre in the University of Calgary. John's a clinical psychologist. Sorry, I'm rereading something here. He's an executive member of the National Cancer Institute of Canada's General Urinary Clinical Trials Committee and past director of Calgary's internship in adult clinical psychology. One of John's special interests is prostate cancer and the sexual concerns of people living with prostate cancer and their patients. He's a consultant to several cancer centres, sexuality programs in Canada and the USA. As well, he has published widely and holds several research grants in the area of sexuality and cancer. Andrea Beck. Andrea is a clinical psychology doctoral student at the University of Calgary and a registered provisional psychologist with the province of Alberta. Her doctoral research was conducted under the supervision of Dr. John Robinson and Dr. Linda Carlson at the Tom Baker Cancer Centre. She plans on graduating this spring, and tonight she'll be presenting findings from her research on the strategies for maintaining satisfying sexual intimacy after prostate cancer treatment. Lauren Walker. Lauren's a clinical psychology doctoral student at the University of Calgary as well. Lauren has conducted research with prostate cancer and ovarian cancer patients, and her interest is in the area of sexuality and sexual dysfunction, and that will be the topic of her presentation this evening. Sofia Lopez Bialabal, sorry. I should have asked you before. So, Sofia is a student at the University of Calgary in the last year of her Bachelor of Arts degree in psychology. She's currently working on an honours thesis looking at peer support groups for the partners of men with prostate cancer. Sofia also volunteers with the Distress Centre as well as Emotional Coding Lab with Janine Davis. Anyway, some of Sofia's interests include health, psychology, prostate cancer, and relationships. So if I could get a warm welcome for our presenters this evening, please. And Dr. Robinson, I'll hand over the microphone to you.
Is this thing come down?
Yeah, I should be able to.
Can I actually read?
Oh, yeah, go for it.
Oh, good. Yep. There, I don't like standing behind podiums. Well, it's good to see so many people out and lots of familiar faces and some folks that I haven't met yet, so it's wonderful to see so many people here. And I'm just the warm-up act. I've come basically to say thank you, and thank you for making the job that I have a whole lot easier. As the psychologist who works with men with prostate cancer and their loved ones, my primary job is to try to ease the burden that cancer places on people's lives. And having a group such as this that I can refer people to makes my job a whole lot easier. Whether I'm meeting a gentleman who's just learned of his diagnosis and wants to learn more about prostate cancer, wants to understand about the treatments, I know that there's a place where he can come, talk to people who have already been through treatment and get firsthand information. I know whether a man is struggling with how his life may be changed after treatment, that again, he can come and meet other people who are struggling finding solutions. I know that the family, the loved ones as well, can come here and be warmly welcomed. There's that old saying that misery loves company. I try to turn it around the other way and say that company dispels misery, and that's what I see that happens at meetings such as this. So I want to thank you for making that part of my job a lot easier. And the focus tonight is on some of the research that we've been doing, and I want to thank you all for supporting us in the research. As I look around, a number of you have been participants in a variety of our research programs. I know many of you have helped spread the word to increase enrollment in those programs, and I want to thank you for that. We're going to focus tonight on two particular studies, one that Andrea has recently completed and one that Lauren has recently completed. And Sofia's going to tell you about a study that she's just started, and we'll invite you to participate in that. There are two other studies that I just want to briefly mention, because some of you may have participated in them and you may be wondering what's become of them. One is the yoga and prostate cancer study. We've just finished that study, analyzed the data, and what we found essentially is that men are willing to participate in a yoga program. Now, I have to admit that when the study was first proposed, I had my doubts. I wondered whether men would enroll in a yoga program, and we found that there was good uptake, that lots of people were interested. And we also found that the yoga did improve men's physical well-being as well as their psychological well-being. So with that information, we're able to go to funders and to say that this is a program that looks like it's viable. And hopefully we will be able to carry on with that program. A second study is what we refer to as our decision aid study. And that was a study to see whether we could better understand how to help men who are newly diagnosed make a treatment decision. And we developed a computer program to try to help during the decision-making process. The first thing that we did was to try to collect the best information that we could about the treatments for localized prostate cancer, and in particular look at what the latest evidence is in terms of the outcomes, cancer control outcomes, as well as side effect profiles, and try to understand how to present that information in a way that's comprehensive, understandable, and that would allow men to directly compare the various treatments. That was a huge undertaking in and of itself, but that wasn't really what we were trying to investigate, because we know that the first step of making a decision is having good information. What the innovation was to develop what we referred to as a values clarification exercise. And what we were trying to do there is to, I guess, help men take the second step in the decision-making process. That the first step is getting good information, but then what do you do with that information? How do you figure out how it applies to you? How do you weigh the pros and cons of the various treatments? So the decision program helped men think through what are the most important considerations when making a treatment decision, and then to weigh out those considerations. In other words, to really clarify for themselves what it is that they value as outcome. So we followed up with men who either got the information or they got the information and the values clarification exercise. And in 6 months, we found that most men were pleased with the decision that they made. There was really no difference whether they'd gone through the values clarification exercise or not. But then we went out and we talked to them again at 12 months. And we found out that there were a lot of men at about 12 months who were actually second-guessing the decision that they made and having what's referred to as decisional regret. The good news is that we found that the men who had actually gone through the values clarification exercise were a lot less likely to have decisional regret. So that's, I guess, confirming for us that we think that we're onto something there in terms of helping people make good decisions. As many of you know, there's now an educational session that's offered through the Prostate Cancer Institute where men can come and learn about prostate cancer and the various treatment options. And so we're trying to figure out now a way of incorporating some form of values clarification for those men who are interested, and then, as I say, having help and then sorting through, okay, what are the important considerations? What do I value? What's the most important thing for me? So I know some of you here helped us with those studies, went through those programs, and just wanted to let you know what the outcomes are. So I want to let Sofia tell you about her study and how you might participate in it if you're interested.
Thank you. Hi everybody, my name is Sofia and I'm working with Dr. Robinson on my honors thesis, which is focusing on peer support groups for the partners of men with prostate cancer. So basically what I want to find out is whether these support groups are beneficial for the women and what can be changed or what can be done in order to make them more effective. So what I'm doing is just going out there, getting women who qualify, and conducting one-on-one interviews that take about an hour, and just asking them about their experiences related to these groups. So if you would like to participate, there's a few things that you need in order to qualify. So you need to be a female. You need to have a partner who has or had prostate cancer. You need to have attended at least one of the meetings of the peer support groups for the women. So not the co-ed ones, it's the ones that are specifically for women. And it doesn't matter whether you still attend or not. And of course, just like with any other research study, all of your information will be kept confidential. So after the meeting, I'll just be over there in my table, and you can just approach me if you like, ask me any questions, and there I'll have my contact information. We can book an interview if you're interested, or you can just take some information home to consider it later, and maybe give me a call later if that's what you would like. So thank you for your time, and hope you have a good night.
Hi everyone. It's good to see so many faces here, a couple familiar faces to me. As is obvious from the title here. Can you hear me? A little bit closer? How about that? Good? Okay. Yell if you can't hear me if I start to drift. Anyways, as is obvious from the title of my presentation, I'm going to be speaking tonight about the results of a research study that I carried out as part of my dissertation research. And I'm going to be talking about what we've learned about sexual intimacy after prostate cancer and what the secrets of success are to maintaining satisfying sex. As many of you probably already are aware, treatments for prostate cancer can result in a lot of side effects that have profound effects on sexual intimacy in couples, from erectile dysfunction, urinary incontinence, bowel dysfunction, changes in orgasm. There's a lot of things that can affect a sexual relationship after prostate cancer treatment. And it led us to wonder, how are some couples able to maintain sexual intimacy after prostate cancer treatment, while other couples really struggle and aren't able to maintain sexual intimacy? And I'm going to step back for just a second and say, what do I mean by satisfying sexual intimacy? Because I think that's an important issue as well. When I say satisfying sexual intimacy, I don't necessarily mean intercourse. I just mean a sexual relationship that is satisfying to both partners. It can include intercourse or it might not include intercourse, but it's some sort of relationship where there's a sexual aspect where both partners would say, we're feeling satisfied with this relationship. So the research question was, how are some couples able to maintain a satisfying sexual relationship after prostate cancer treatment while other couples are not? And the study was what we call a qualitative study. So that means I didn't use numbers, I used words. I did interviews with couples. Each couple had 3 interviews. So there was one interview with the couple together, and then there was one interview each with the woman and with the man. And I tried to figure out what it was that couples who were successful were doing that couples who weren't successful maybe hadn't tried yet or weren't doing. And what I found, I'm not going to go too much into the background details, but what I found were that there are several qualities that couples who are able to maintain a satisfying sexual relationship had. And these qualities were acceptance, flexibility, and persistence. And I'm going to talk just briefly about acceptance first. So in terms of acceptance, there's several different types of acceptance when it comes to a sexual relationship after prostate cancer. One is accepting the current situation. So those people who were able to accept the current situation that they were in and move past any resentment, any anger, and loss, they were more able to put their energy into finding solutions to recreate that sexual intimacy. But people also needed to be able to accept their feelings and their partner's feelings, so the reactions that different people had. So some people had to come to terms with the fact that I'm really angry about this loss, or that I didn't think I was the kind of person that needed a sexual relationship, but I really do. And then also to accept how their partner reacted to that. So whether their partner was kind of blasé about it, or whether their partner was really pushing for sort of recreating that sexual relationship. So being able to accept both your own and your partner's feelings was really important as well. Also important was accepting a different way of having sex. So sex changes as a result of the side effects of prostate cancer treatment. Whether it's using assistive aids, such as the vacuum erection device, or medications such as Viagra or Cialis, or using penile injections, or whether no assistive aids are used, there's likely to be a change in the way that sex is carried out between a man and a woman after prostate cancer treatment. It's likely to feel different, and it's likely to progress differently. And couples who are able to accept that difference, that change, but still value their sexual relationship, they were better able to press past the challenges to recreate something that was satisfying for both of them. So accepting that there is this big shift and this change in the relationship, but still value that. Also accepting imperfect sex. So couples who were able to accept that some days, given that they were often trying new solutions, some days sex wasn't so good, and that was okay, that it was still a valuable encounter that they had with their partner. And to also accept that one bad day doesn't necessarily lead to every bad day. That one sexual encounter that was sort of doesn't mean that tomorrow or next week or next month is also going to be similarly So those couples who are able to accept that in this period of trying to recreate a satisfying sexual relationship, that there were going to be good days and bad days, that was okay, these couples were able to sort of push past that as well. In terms of flexibility, I think that's photoshopped. I don't know. Flexibility was also an important characteristic. So firstly, flexibility in the types of sexual activities engaged in. So what I found was that because sex has changed after prostate cancer and new challenges are introduced, it was really helpful for couples to be flexible about the different types of activities that they called sex. So couples may have needed to engage in more foreplay. They may have needed to do more pre-planning instead of being quite so spontaneous. They may have had to make modifications in position or pressure. They may have needed to engage in oral sex for the first time, or more oral sex, more manual stimulation. So what we found is that couples who could be flexible about trying new things, about what fit into their definition of sex, those were couples who were better able to find a solution in the end. And also flexibility in communicating with your partner after sex. So we found that couples who'd been together for a long time often developed a sexual repertoire that was pretty established, that didn't need a lot of explicit communication. But after prostate cancer treatment, things are so different and so new that explicit communication was needed before, during, and after sex. And this was often kind of awkward and even embarrassing. So in a relationship where you've been together for so long, it may feel like, why do I feel so strange here? But it's almost like having sex with a similar partner in a really dissimilar way. And so there was this communication needed to allay fears, to talk about concerns, to talk about, yeah, I like that, or no, I didn't like that. And that was often a real struggle, as couples often felt kind of new and different at this. So couples who are able to be flexible in that type of communication were also better able to keep on pressing forward. And that leads me to another quality of persistence. First, I found that persistence in finding solutions to sexual challenges was really important. So even in the face of formidable challenges to the sexual relationship, those couples who could persist until they found solutions that worked were more likely to achieve that satisfying sexual relationship. It takes a great deal of fortitude to just keep on trying, push past those experiences that weren't so satisfying or felt awkward. I found a good quote today, actually. It said, persistence isn't using the same tactics over and over. That's just annoying. Persistence is having the same goal over and over. And that's by a guy named Seth Godin. I don't know if anybody knows who that is, but I found that quote today. Persistence was also really important in continuing to do what works. So what we found was that when couples were able to find something that was even mildly successful, if they made note of that and they continued to practice with that, it often got better over time. So if they took little tiny successes and they just kept practicing, they often became big successes. And also if couples were able to remember what used to work for them, then even if that needed modification, often relying on those old things but just doing it in a different way was actually really helpful for people. And then finally, continuing despite predictions from others was an important component of persistence. So often people would say that, well, I talked to one of my friends and he wasn't able to continue sex with his partner after prostate cancer. I don't think my chances are very good. Or my doctor said, you know what, forget about that. That's not going to happen. So people who were able to persist despite predictions from other people, who are able to say, you know what, this is my relationship and I'm going to push forward to create something that's satisfying for my partner and I. And conversely, people who were able to persist despite sort of overconfident information from other people. So people who might say, you know, it's not going to be a problem at all. There's not going to be any changes. You're not going to have any challenges. It'll be fine. So people who are able to persist through that information as well seem to do a little bit better. So that's all well and good. But when I got to this part in the analysis of my research, I stopped and I said to myself, why? Why are some people able to be accepting, to be flexible, to be persistent? What makes some couples able to have those qualities when other couples maybe don't? And so in that question of asking myself why, it came to this idea of what motivates people. What do people value? Because I think that those characteristics are kind of easy to have when you're motivated, when you really value putting that effort into that sexual relationship. And so what I found is that motivation exists where one's values lie. And by and large, there were two reasons that people really valued sex. One of them was for relational intimacy. And what I mean when I say relational intimacy is that feeling of being emotionally close to another person, feeling connected, feeling a sense of well-being in relation to one's partner. So I use this term to describe intimacy in the context of a romantic or sexual intimate relationship. As well, people valued sex for the physical pleasure. So when I say physical pleasure, I mean that release, the gratification, the satisfaction, the pure enjoyment of the physicality of sex. So it's a relative focus on intercourse and orgasm as the method and the goals of sex. And people will often describe sex as being a release or a stress reliever or a tension reliever, reducing anxiety. Okay, so those were the main two reasons that participants talked about enjoying sex or valuing sex. So what I did was I created a graph. And what you'll see, let me see if I can find a mouse for you here. Yeah, here we go. Okay, so on this vertical line, there we go. So this is the measure of how much a person values sex for physical pleasure. So at the top of this line here, let me get my thingy back. At the top here is where you would place somebody who really, really values physical pleasure. At the bottom would be someone who places a pretty low value on sex for physical pleasure. And then across this horizontal line, this end would be someone who really places a high value on sex for relational intimacy, and at the other end would be somebody who places a low value on sex for relational intimacy. Okay? And what I found, and I'll describe each one separately, but what I found is that depending on where someone falls on this graph, certain outcomes can be predicted. Okay, so we'll talk about individuals rather than couples right now. So there can either be an apathy towards sex. There can be, hello, thank you. There can be frustration after prostate cancer. There can be intimacy without intercourse, so sexual intimacy without intercourse. And then there can also be intimacy with intercourse. So I'm going to talk first about apathy. So apathy is when a person has a low value placed on sex for both physical pleasure and for relational intimacy. And what I found with individuals who felt like this was that sex was rarely a priority in the relationship before prostate cancer, and prostate cancer just added a whole nother layer of difficulty onto that relationship. So there was often a low motivation for addressing sexual challenges, and there's sometimes an ambivalence as well of I know that I wish that this were more important, or I wish that we could figure this out, but sometimes words with little action. So there wasn't a lot of follow-through, wasn't a lot of persistence, and oftentimes if this person or the couple had been in any sex treatment with the psychologist, that often not a lot of headway was made. Now, someone who places a high value on sex for physical pleasure, but a low value on sex for relational intimacy, often found themselves frustrated after prostate cancer treatment. Because prostate cancer treatment really blows at that physical functioning, when the value is placed on physical pleasure, the impetus for having sex is really just taken out from under the person. So if there's a low value on relational intimacy, there's sort of this frustration of, I'm trying to have sex for physical pleasure and it's just not working. I can't have intercourse like I used to have. If I do have intercourse, it doesn't feel the same way that it used to feel. Orgasms are different, and I'm just frustrated. Okay? Often these types of people were sort of highly motivated at first, but found themselves really frustrated and giving up after a little while. They were relatively inflexible about the definition of sex. So sex was really about intercourse and orgasm. That was kind of the definition. Now, someone who placed a high value on sex for relational intimacy, but a low value on sex for physical pleasure, often did pretty well after prostate cancer treatment, because the relational intimacy wasn't the part of the relationship that got the blow, it was the physical part. So these people were often very flexible about the definition of sexual intimacy. It was less about intercourse and orgasm, more about relating to their partner. And they could do that in a lot of different ways, even sexually. And so these people were often very motivated to maintain intimacy, but they did often give up on trying to find what we call penetrative solutions. So that's solutions to actually restore intercourse. So these people would often stay intimate, stay physically, sexually intimate, but kind of give up on restoring intercourse. And then finally, somebody who was high on the value that they placed on sex for both physical pleasure and for relational intimacy. These were sort of the superstars, in a way. These people had a really high priority placed on the sexual relationship both before and after prostate cancer. They were often really, really tenacious about finding solutions for penetration, so for intercourse, but they were often also pretty flexible about their definition of sex. So even though they were very, very motivated to have intercourse again, they really valued just that intimacy. So even if it didn't really go well, even if they weren't able to have intercourse, there was still a really high value placed on that experience itself. These people are often very persistent, even when libido was reduced, even with failures and challenges, they were persistent because they kind of had this double whammy value placed on sex. And they often had sort of a never give up or just do it attitude, just keep on trying. So what happens when you have now two individuals who are in a relationship together who may or may not have similar values? So what I found was that partners, I think more often than not, differed in their relative value placed on sex for either relational intimacy or for physical pleasure. That wasn't always a bad thing. Sometimes partners misunderstood each other's values, and that without being able to speak to one another about it, it created some misunderstandings between couples. So why isn't he trying harder? Why doesn't she want to help me restore erections? And there wasn't sort of an open communication about, well, what do I value about sex, and what do I want to hold on to, and what am I okay letting go? And how can we work together so that both of our values are supported? What sometimes happened when couples didn't have similar values was that there was a fracture in the relationship that it was very difficult to get past. Other times, the difference in values was actually complementary, such that one partner was able to support the other person's value, even if they didn't hold that value themselves. So I'll give you an example. There was one couple in which the man really, really highly valued sex for both relational intimacy and for physical pleasure, and his partner valued sex highly for relational intimacy, but not so much for physical pleasure. So when he got prostate cancer and experienced erectile dysfunction, she wasn't too upset by it. She was more interested in maintaining some sort of intimacy, whether it was intercourse or not. He, on the other hand, was absolutely adamant that they were going to restore intercourse. He enjoyed all sorts of different sexual activities with his wife. He was able to value that relational intimacy, but he was tenacious about restoring erections. And because this woman loved her husband and valued the sexual intimacy that they had, she was willing to step up and support him in his search for penetrative solutions, so solutions to restoring erections. So even when couples' values weren't exactly the same, it sometimes worked out very well that they were still able to support each other. So that's why I said partners may influence one another for better or for worse. So in a nutshell, what we found was that sexually satisfied couples were more likely to believe that sexual functioning is dynamic. It takes you back to that comment I made about sometimes it works well, sometimes it doesn't work well. But it not going well is not an indication that every day it won't go well. They were able to accept their current functioning. It doesn't mean that they were willing to stay put, but that they accepted where they were at now, took a realistic view and took stock of where they were at so that they knew where they wanted to go from here. They were flexible about different sexual activities and the sexual outcomes. They were purposeful about making sex a priority. And one of the best examples of this is that most of the successful couples were those that planned sex, that said, you know what, because I'm using injections or because I'm using Viagra or Cialis or whatever it was, that I can't always be spontaneous. So they would plan sex. They would say Saturday mornings or every third Saturday or whatever it was. It was always pre-planned, and they made it a priority that, you know, barring any unforeseen circumstances, this is a time we set aside for us to engage in sexual intimacy. Couples that were successful were more willing to take emotional risks with one another. So they kind of had that foundation of that relational intimacy where they really trusted one another and were willing to kind of feel awkward and be okay with this new situation and trying to figure out this new sex with an old partner. And they were able to persist despite sexual dysfunction and failed attempts at intercourse. So they so valued that relational intimacy that even a failed attempt was a positive attempt because it was time spent with someone that they loved and that they wanted to put that effort into the relational part of the intimacy. So overall, what we found was that the essential feature was really valuing sex primarily for relational intimacy. So how is this useful? What this model does is it helps individuals understand their own and their partner's reasons for valuing sex. So without that schematic, I don't know that any of us would be able to step back and say, what's the reason I value sex and how does that relate to how my partner values sex? But by having that schematic and being able to place yourself and your partner, it helps people to understand sort of why we might be having the difficulties that we're having. It also helps individuals understand what motivates and demotivates them and their partner, and how to maintain their motivation. It allows individuals to predict what might happen if they can shift their values. And I think that's a really, really important point, that we may go into this having a certain set of values. It doesn't mean that we're stuck there. There's no reason that we can't work to shift our values. If we're the type of person that really valued sex for physical pleasure and not so much for intimacy, well, maybe that's a good sign that we need to work on valuing our relational intimacy. And I think that's one of the things that Dr. Robinson and I are most excited about. It's one thing to be able to say, where are you now? It's another thing to say, how can I change? How can I get better? How can we create something that's going to be satisfying for both of us? And that might mean a shift in values. And then this model also helps couples accept their situation, be flexible about solutions, and persist in their attempts at maintaining sexual intimacy. So that is it for me. Thank you to all of the couples who participated in this research and made this research possible. And I'm going to hand it over to Lauren now. I think we're going to save questions for the end. Thanks.
So I think it's nice that Andrea was able to present her research first. My research is also in the area of sexual adaptation to prostate cancer treatments. But what I'm going to do is focus specifically on androgen deprivation therapy. So that's a common treatment for prostate cancer, also referred to as hormone therapy. So for those of you who are familiar, bear with me as I just do this refresher. But androgen deprivation therapy, like I mentioned, is a common treatment for prostate cancer. And depending on the source you look at, it's an estimated 600,000 American men are treated per year through hormone therapy or androgen deprivation therapy, ADT. And what we know is that the survival rate of patients with prostate cancer is often estimated to be at least 10 years. And so sometimes these patients will actually go on this treatment and be on this treatment for 10 years or longer. So what we find is that if you're going to experience side effects of these treatment, it will be quite a while that you will actually be living with those side effects. And so I was interested in what we could do to actually explore what it's like to be on this treatment and to experience these side effects and see if we can do anything to help ease the experience. So side effects of ADT include medical risks for diabetes or cardiovascular disease and osteoporosis, but also physical side effects like hot flashes. Sometimes men experience breast growth or loss of muscle mass. And then, of course, many men have also been on other primary treatments for prostate cancer, such as surgery or radiation treatment. And so you get to kind of an accumulative effect of side effects. So often they've experienced erectile dysfunction already or urinary incontinence, as Andrea mentioned. And so these are added side effects if you're also going to be on the hormone treatment. But most times when patients are prepared for this treatment, they might be given a list of side effects and kind of told to go home and think about what the side effects are, but very rarely are they actually given tools to deal with those side effects. And also rarely are the partners of patients prepared for those side effects. So while there's lots of research on what the side effects are, there's not very much research on how men are dealing with the side effects and how couples are adapting to those side effects. So I was interested in what are the changes that are associated with ADT and how do those changes impact relationships? And more specifically, how are couples adjusting to ADT? And what I found through interviewing couples was that while it can be difficult to adjust to physiological side effects that are uncomfortable, such as hot flashes or a loss of muscle mass and fatigue, what came up often in these interviews, perhaps because it was in a couple setting, was that sexuality was a very challenging area to adapt to after being on ADT. So I was able to interview 18 couples. So just as Andrea mentioned, this was also a qualitative research study. And so I asked couples those two questions. So what are the changes you've experienced? And then how are you adjusting to the treatment? And so couples were able to kind of identify what was important to them in the interview. And so what I was able to do was to look at the outcomes of those patients and find out how people are adapting sexually after treatment. And so I found that some couples are able to adapt quickly to not having a sexual relationship. So some couples, for reasons of their own, perhaps maybe they're already dealing with a reduction in sexual frequency as they get older, or they perhaps could have other health issues that may have presented sexual challenges previously. So these are couples that maybe have already decided to have less sex in their relationship anyway. Also, what I found was that many couples were told ahead of time, often by the medical profession or by looking online and finding out their own resources, that it's difficult to maintain a sexual relationship after ADT, if not impossible. So sometimes people were warned that this could be an impossibility. And so some of these couples that adapted quickly were couples that believed that it wouldn't be possible to maintain a sexual relationship. And so these couples were fine and satisfied and happy with that outcome, and they were able to accept this and move on. But what I also found was that other couples really began to struggle with this decision about whether or not they try to maintain a sexual relationship or whether they give up on their sexual relationship. So sometimes these couples were struggling with this decision and sometimes would waffle back and forth. They may choose to not be sexual and then find that they were trying to engage sexually at a later time. Or they may choose to maintain sexual relationship but then find that the challenges in doing so were difficult and that they decided to later abandon their decision to maintain sexuality. And so I did find, in fact, one of the couples that I interviewed had been struggling for over 10 years with that decision of kind of going back and forth and were really hadn't found any solutions that were working for them. But what I did find that is promising is that other couples, despite struggling for a while, were able to maintain a satisfying sexual relationship despite being on ADT. So this led me to conclude that those couples that had been warned in the beginning that they may not be able or should not be able to maintain a sexual relationship, that actually may not be accurate. So there are couples that maintain satisfying sex after being on ADT. So there's hope. So when I spoke with these couples, I was curious what some of the reasons would be for why couples would be interested in maintaining sex. And I think this complements what Andrea was speaking about quite nicely. So for these couples, they identified that sex was important to either or to both partners. So again, there doesn't have to be the same values for each member in the couple relationship. So if it was important to one or to both partners, then there was some main reasons to maintain a sexual relationship. One of those reasons would be that it helped to maintain intimacy within the relationship. So sometimes couples find that there's no better way to be intimate than to be physically intimate with each other, or that physical intimacy opens the doors for more communication and more talking and more beneficial parts of intimacy that may not necessarily be physical, but that would be relational. Sex can be enjoyable. So it brought enjoyment to couples, and that it was an important part of their relationship that they wanted to maintain. So some couples identified that it provided a necessary release for them. Again, it could be anxiety reducing or a way to release physical tension that's built up, and just a necessary part of their relationship. Some people identified that a good sexual relationship can compensate for other faults in the relationship. So if you forget to bring home the milk or whatever thing that people may kind of pick at each other about, as long as things were going well in the bedroom, sometimes it could kind of be that that lubricant that kind of, made couples gloss over some of those difficulties. And I did have a few couples that actually mentioned that their sex lives had improved since being on the hormone therapy. This is interesting. I find because one participant actually mentioned that she had never really been very interested in sex, and her partner was a lot more interested in it than she was. And so as he was on the hormone treatment and his libido softened or decreased, he was less interested in it, and they were able to kind of match each other's interest for sex. So he was less pressuring for her, and she was more willing to engage on occasion. So what I'm going to do is just highlight some of the challenges that both partners and patients described, and then also some of the specific strategies that couples were able to use to get over those struggles that they had experienced. So keeping in mind that some couples are able to just kind of let the sexual part of their relationship go, and then some couples are struggling for quite a long time to deal with some of these challenges. And then other couples are able to find those successful strategies. So what I thought would be most helpful is if I help to highlight some of those strategies. So here specifically some challenges described by partners. So partners described feeling that once sexual activity was less frequent, they often felt as if they were ignored or unnoticed by their partner. And so while the patient may not have intentionally done something to make the partner feel ignored or unnoticed, what I found was that partners were describing that now they may walk across the room naked and not get a glance from their partner. So while that once may have been a positive thing for them, helping them feel like they have good self-esteem and that they can create that reaction in their partner, that was definitely missed once their partner was less sexually focused. So partners also described missing the intimacy that they once shared when they were engaging in sex. And so, like I described before, sexual relationships can often open the doors for communication and for sharing that sense of intimacy. So couples that were now not engaging in sexual intimacy as much may have noticed a decrease in intimacy in general. And so even patients that now they're not engaging in sex anymore may have even kind of forgot to engage in any sort of physical affection. And so partners were describing feeling that they maybe even lost that kiss on the way out the door. So kind of forgetting to engage physically in hugging and kissing and cuddling and all of those things that were once taken for granted. Once sex is off the table, they felt as if some of those things went by the wayside as well. And then lastly, one of the other challenges described by partners was that sex often didn't occur because the patient wasn't initiating it. And so many of the women that I spoke to described being raised in a time where they were taught to not necessarily be the sexual initiator, and they may have had reservations behind being a sexual initiator. And so if the patient wasn't initiating sex anymore, who's left to do the initiation? So for strategies here, these are things that the patients were describing that they were doing that was helpful for them. So as I mentioned, when the partners were feeling that they were now kind of going ignored or unnoticed, patients were starting to make more of an effort to show physical affection to their partner. So not letting that go by the wayside, remembering to do the kisses on the way out the door, and remembering to make a point of cuddling and having a physical intimacy that doesn't necessarily have to lead to sexual intimacy. So sometimes patients described being kind of worried that they would maybe start something that they couldn't finish. So if they started kissing with their partner, then the partner might assume that they had to lead to a sexual encounter, whereas often the partners just were missing having that physical connection of kissing and hugging and showing affection to each other. So the patients were able to put in more effort, then the partner didn't have those same feelings of being unnoticed. So I had some patients describe that they had to remind themselves of how important sexual activity was to their partner. So even if they weren't as interested in sexual activity anymore, they were willing to engage in sexual activity because it was satisfying for their partner. And often, once they were willing to start in a sexual activity, many of them even identified that it was actually satisfying to them as well, even though they didn't consider at first that they were interested in sex. But once they were engaging, then it kind of spiked their interest. So I just have a quote here that I thought really summarized that. So this patient said, "I get some pleasure on my part, but a large component of it is that I know it brings pleasure to her. So part of it is that he knows that she's enjoying the experience, and part of it is that he did start to enjoy the physical experience more as well." And then another important factor was engaging in sexual activities despite a lack of libido to motivate them. So as I mentioned, if the man is typically the initiator and the woman has never felt comfortable being the initiator, then you could see how sexual activity would cease if there was nobody left to initiate the activity. So the men here described just kind of engaging in sexual activity despite that loss of libido and despite feeling unmotivated, so engaging in it anyway. So some of the challenges that patients were describing. So again, not wanting to initiate sex if they felt little desire to. So why would I start something if I'm not really interested in it? So given, what I've just said in the previous slide, there's another reason there for engaging in sex is perhaps to please your partner. Patients also described feeling frustrated that sexual experiences weren't the same as they were before. So again, as Andrea mentioned, couples can get into, have a sexual script where it's implicit what's going to happen. You know what works for your partner, so those are the kinds of things that you engage in. But after having treatments that affect that, you may find that different things are satisfying than what you're typically used to. And so couples would identify frustration that either things weren't successful, the same experiences that they used to have weren't working the same way that they were, or that they didn't feel the same way, or that they just weren't as satisfying. And then also I mentioned that they were worrying that they couldn't satisfy their partner. So kind of worrying that their partner may even seek satisfaction elsewhere if they weren't able to provide it for their partner. So the partners here were able to describe strategies that they were using to help the patient allay some of those worries and fears that they had. So partners described becoming more responsible for initiating sexual activities. So even though they typically weren't the initiator, now they may take on more responsibility for initiation. And for example, one person said, she said, "I took over the role of initiator, which has been wonderfully freeing for both of us. It has added a richness to our intimacy and allowed him off the hook to start what he has no inclination for." And the second point there is that partners also described not waiting for that spontaneous initiation of sexual activity to occur, but actually scheduling times to be intimate. Now, sometimes when you suggest this to people, they think that that's a bit weird. We've never had to do that before. Why would I schedule that on a certain time during the week or during the month I would be interested in engaging in sex? But what couples found was that was kind of a safe spot, a spot that wouldn't get taken away with the busyness of life. And when you're struggling also with fatigue as a treatment strategy, or as a treatment side effect, a strategy for scheduling time to be intimate could be to do that in the morning, perhaps, when you're not also struggling with the fatigue of having gone through a busy day. So partners also described that as a couple they were able to focus less on intercourse and more on sexual touching. So focusing less on the way things had been before, and focusing more on just sexual satisfaction and gratification and touching with each other, and just kind of being more flexible in how they defined what their sexual relationship included. And then also appreciating the process of sex. So rather than just the goal of sex being often intercourse or orgasm, appreciating the whole process of sex and engaging with each other in that whole activity, and learning to communicate about what each other's expectations were, what people actually were enjoying, what they weren't enjoying, and also one of the important things that couples were identifying was just being willing to experiment with things. And if you do that in a safe environment, being able to laugh about them if they didn't actually work out the way that you had expected. So this person says, we laugh a lot more when we make love than we ever did before. I think that's actually added a huge dimension to our lovemaking. So just to summarize, we have some characteristics of couples that are more successful in maintaining a sexual relationship. So these couples were couples that were unwilling to accept a loss of sex within their relationship. So rather than accepting that idea of that sex might be impossible for them, they kind of pushed that aside and said, well, maybe we're different and maybe we can try this anyway. So these couples were motivated to maintain sexual contact, and this complements Andrea's model nicely because she provided some reasons for why couples may be interested in maintaining sexual contact, whether it be for relational intimacy or for the physical pleasure and enjoyment. And I think one of the most important things is that these couples were really quite open-minded about specific strategies. So not holding to very rigid definitions of what a sexual relationship should look like or what it had looked like before. So being more open to sexual experiences that maybe they hadn't tried or had kind of had forgotten about. So these couples were also willing to adapt their definition of sex. So sex doesn't have to be rigidly defined as penetrative intercourse. So they were able to kind of enjoy a more broad sense of what includes sexual activities. And they placed a great emphasis on increasing relational intimacy. So if sex was important for relational intimacy, then they were able to engage in it and see more benefits to sex than just for physical pleasure. And again, these people were considerably perseverant. So these were couples that were willing to continue to try strategies, even if they had failed before, or even if they expected that they had failed from what they had heard about other people. So this leads me to a question of how to best prepare patients for ADT. So if we're finding that some people are told ahead of time that they may not be able to maintain a sexual relationship, some people are able to quickly adapt to that, being that they assume that it's an impossibility for them. But I'm kind of wondering if it would be helpful for them to hear that it is possible to maintain a sexual relationship. And for those couples that are continuing to struggle, would it be beneficial for them to hear what was helpful for other couples? So patients are often reporting not knowing enough about the side effects that they experienced as a result of ADT. And so being that the side effects can be hard to predict, and you don't know if you'll experience them or not, what we're doing is trying to start a new study where we evaluate if it's effective to educate patients ahead of time about those potential treatment side effects. And then partners are often reporting that they are also affected by the patient's adjustment to ADT. So we can't forget that just because one patient has prostate cancer and receives the injection and actually is the person that's got the medical file at the hospital, that their treatment side effects aren't also affecting their partner and their family members. And patients are often told that they will be unable to have a sexual relationship. So again, as I've mentioned, it might be helpful if they knew that that wasn't necessarily true. And as I mentioned, patients may benefit from learning from other couples. So what we've done for the next step in this research, what I've presented so far has been my master's research, and I'm now carrying out a study for patients that are newly starting on hormone therapy. And so what we're doing is trying to get patients that haven't that you can have been on hormone therapy before, but if you're starting on it now, what we want to do is to get you and your partner, if possible, to enroll in this study and get you to fill out questionnaires to let us know if it's helpful to know this information. So we have an educational booklet that is given out as part of the study, and your questionnaires are able to help us evaluate whether or not this is actually helpful. And so the educational booklet talks about what hormone therapy is, how it affects the body, what are the side effects associated with the treatment, and what are some of the strategies that you can do about the treatment side effects. So given what we know about what couples are doing that's helpful and what's not necessarily helpful, we've been able to integrate this all into this booklet. So that's the next step, is just finding out how helpful it is to give patients all of this information up front. Or perhaps it might be something that patients just want to seek out for themselves, going through counseling routes and that kind of thing. So what we're doing is just evaluating that as the next step of our study. So what I'd like to do is also open the floor to questions and invite Andrea up here for if other people have questions for either of us or for John.
So one of the things that we'd like to know is if this information is at all helpful to you folks who are here. What we try to do at the Cancer Center is not just to rely on our intuition or our best guess about how to provide good service, but we conduct research to test out some of those assumptions. And one of our reasons for coming tonight is to share with you some of the things that we think that we're learning, and in essence to try to get some feedback from you folks as to whether you think that Lauren and Andrea got it right, or where maybe they didn't get it quite so right, whether you think we're on the right track or the wrong track. So we would sincerely welcome any comments or reactions, or any questions about any of this?
Well, I'll start out. I'd just like to say thank you for your presentation. I found it very good. I've been through all three. I've had a radical prostatectomy, I've had radiation, and I had 18 months worth of hormones that I'm off now. And a lot of the things I related to very much. And I'm really pleased that you're able to speak frankly about things like this, because this is kind of a taboo for men. No one really likes to talk about the change. No one really likes to talk about the changes that do take place, and they are changes, and I did have changes. And we still work our way through these changes. But a lot of those things I really relate to, and probably we've tried, you know. So again, thank you very much.
I was particularly struck by Andrea's graph, the vertical and horizontal. And I'll bet every man here knows exactly where he is.
And woman too, probably.
We're paying attention. You're right. We all know where we are. And it was very helpful.
Thank you.
On behalf of the women here too, I think it's very
Let me just, sorry. I want everybody to be able to finish.
I think it was very helpful, actually, myself being a partner of somebody that has had prostate cancer, and that I feel that this is actually very important to know these things, that there can be intimacy, like you put down, there can be intimacy if maybe without the physical contact or vice versa. And I think it's important for the men here to know too, as far as women are, that these things are important for us, even though perhaps if they've had the ADT therapy and that maybe there's not all that, they're not as much concerned about sex and that as they used to be, but it really is important sometimes for us women. We haven't gone through this and that, and I just think it's important that they've heard this and that they know that there are ways that you can, you know, please us without sexual intercourse and so forth. So I think it was very, very well done.
There we are.
I'd say thank you very much for putting this on, and it's useful, and yeah, especially the chart, and I'm sure the women too can identify where they are. And I think a lot of men think that they have a particular idea what the most important organ is, but I think that the skin is the most important organ, and women's skin is especially sensitive all over the place. And I mean, just cuddling and stroking and things like that are so important and very exciting.
Yeah, I guess my question is really for Andrea, but it sort of applies to both. I was wondering, in terms, you mentioned you interviewed the couples then individually each, and I was wondering how long a period of time that was over, and sort of in relation to that, once they were able to quantify or at least put themselves in the chart somewhere, if they mentioned over the course of your study any changes they had noticed because they were able, you know, because they were able to relate their relationship in that regard.
That's an awesome question. Do you want to wait for them?
We are going to get another mic.
Thank you. To answer your first question, how long between the combined interview and the individual interviews? It was a minimum of 1 week. Sometimes it was up to 3 or 4 months, just depending on when we could schedule another interview. And in terms of the second part of your question, we hadn't figured out the whole graph by the time we had done the second interview. So I sort of collected all of that data, all of that interview data. Then I sat down with it over a period of 1.5 years, 2 years of looking over these interviews. I think I did 51 interviews total and took a very long time to go through all of them. And that's when that model developed. And what I then did was wrote up a research summary with the graph and gave a questionnaire out to all of those participants who participated in this study originally. I've done that recently. I think I've received back 16 questionnaires from participants, and by and large, individuals are saying that the model makes sense to them, that it quite well, not always perfectly, but quite well captures their experience. And there was an opportunity to place themselves on the graph. Unfortunately, what I found was that I needed to give a little bit more information about how that graph works. What I was hoping is that each individual would plot themselves and where they think their partner is on that graph without necessarily talking to their partner, so that I could then compare the two. What I found is that a lot of partners either put 2 dots on the graph, sort of where they are vertically and where they are horizontally, or put 2 dots but didn't indicate whether that was me or my partner. And so I'm not sure that I'm going to be able to make a lot of use of that. But I really like your question about did they see a change over that amount of time. I'm not sure I can answer that because I think most of my interviews were too close together to be able to do that. But I think that's a really neat next step, to sort of take what we now know or what we now think about this model and then sort of present that to people and say, if we present this to you and kind of explain what we think might be going on, does that help you move forward? I think that's a really neat next step.
How come you're always at the other end of the room?
I found your presentations tonight really good. The graph is going to remain with me for a long time and to evaluate. And over our process over the last year, I think it's so important that our doctors have an opportunity of hearing this talk, because I think they set us up for an unfair expectation of what will happen afterwards. And it's very frustrating to work with that and work with the reality. So I hope at some point you'll have an opportunity to present that to the doctors who are dealing with us firsthand.
Absolutely.
Because it was very well presented.
Thank you. That's our plan.
Okay.
All right, if that's it for questions.
One here.
Oh, one more question.
Thanks.
Yep.
Well, I agree that was an excellent presentation. I think that I talk to people most often related to prostate cancer who were just on the waiting and watching. And you know darn well what the big concern is. It is they'd rather lose an arm and a leg, but they are going to do some waiting and watching and see what develops. And I think at that very early stage, as well as what you're talking about here, when they're first diagnosed with some form of prostate cancer, that would be a great opportunity to take them through something like this so they don't get the shock all at once when they find out they're not going to be able to perform like they did before. So this education is really beneficial, not only to the people that are on ADT, but even the ones that have just been diagnosed, so they know what the heck's ahead of them. They don't get it there, get it behind the barn, and they won't get the right story back there. Thank you.
Yeah, but that might scare the hell out of them. They won't go forward.
I don't think so.
Well, let's get another big thank you to.
One of the questions that arises when we talk. One of the questions that arises when we talk to women is they ask if physicians, if the urologists, and this is a question for you, Dr. Robinson, downplay some of this information. I mean, we just hear that patients aren't aware often what's going to happen or what might happen. And so the question that women seem to raise is this information downplayed because doctors worry that if patients knew right up front all of the possibilities, they might make other choices in terms of moving forward with treatment?
I think some of the family physicians, some of the urologists do downplay the side effects. They minimize it, whether it's the primary treatments with the androgen deprivation. I mean, that's what we were hearing from a lot of men, is that the side effects were downplayed, minimized, and that a lot of people were angry that they hadn't been appropriately prepared. And one of the reasons I think is that you don't want to scare people off, right? Hopefully part of the message that came through is that while there are changes, it doesn't have to mean the end of one's sex life. That if you're willing to persevere and be flexible and to look at your own values, have communication, in some cases seek help, that prostate cancer, well, it's not the prostate cancer, it's the treatment, it doesn't have to spell the end of one's sexual life. And you know, what was really gratifying to me with what Lauren did was particularly with quotes unquote the worst treatment of androgen deprivation therapy, that couples there still can have gratifying sexual relationship. And I have to admit that until I really started to work in this area, and some of you may remember a fellow who came to talk to us here a couple of years ago, Richard Wassersug, really challenged me to open my own mind about what does it mean to be on androgen deprivation therapy, and that, you know, that if we provide the appropriate help, that we can relieve a lot of the suffering, help couples continue to enjoy that important part of their relationship. And so whenever I get a chance, as you know, I try to help urologists find ways of explaining this that hopefully will inform patients, but don't scare them off, and that let them know that there's help available. They don't have to suffer in silence at home. And of course, I mean, the other thing that I really look to this group is that you have tremendous influence. When you go and you see your physicians, your urologists, you can educate them, right? You can help them appreciate and understand the things that they did that helped you through the process, that are helping you live well, the things that maybe you've learned or discovered that might have been helpful. Urologists sometimes, when they're hear me talk, well, it's John talking again, and so on and so forth. But you know, when you guys go in, I think you have a lot more sway than maybe what you give yourselves credit.
I'm reminded of a one-liner: "Dead men don't get erections."
Are there any more questions? Oh, you good?
I think one of the things that would really help us in that persistence is if they would come up with a solution to replace testosterone. I went to my doctor, you know, talking about I'd like a little jolt, you know, to get it up or whatever else, and just feeling really good. And he said, that's like throwing gasoline on fire. And I really don't believe that. I don't know. I just, somehow or another, I don't know if testosterone really does feed cancer. And, but I know when they gave me the medication to take it away, it did a really good job.
So I don't want to keep you too late. I'll let you get on with the rest of your meeting. Just a reminder for Sofia that if there's any women here tonight who have been participating in the women's support group, she'd really love to talk to you. What we want to do is to see whether we can enhance that program, give some feedback to the leaders, and make sure that that program is working just as well as it can. So if any of the women here are willing to meet with Sofia, please let her know. Thanks.